I think so. This is something useful. LFT. Anyhow, what we have eaten now, we can put a small diagnosis into. Liver function tests in children, in adults, wherever, is always a confusion. Small values this way, that way, we get into confusion. We get into trouble at times also. I think so. Dr. Rama will highlight some of the facts and keep us on track on what is to be done. Over to Dr. Rama.
Thank you, chairpersons, for the kind words. Thank you, Rajesh. And good afternoon, ladies and gentlemen. I acknowledge with a lot of respect a lot of my teachers who are amidst the audience now, Riya sir, Najiba ma'am, to name a few, and all our young faculty at that time who are very senior faculty at Calicut Medical College, and a lot of my classmates too, and juniors. Thank you. Thank you for the opportunity provided. My talk will be on LFT in children. It's a very vast topic, as I know, as all of you know. And I bring you greetings from Maulana Hospital, Perindalmanna. And instead of making it a theoretical discussion, I thought I'll just introduce a few case scenarios to you, and then generally deal with LFT, its individual components, the patterns and interpretation. And then I'll go back to the case scenarios and try to interpret them so as to give everyone a very basic and simple idea. I have kept it as basic as possible because this is a very basic topic. So the first case is a short febrile illness in a 6-year-old with vomiting and yellowish. So as I told you, I'll deal with the case scenarios, then just go to the basics of LFT and go back to the case scenarios. So this was a short febrile illness in a 6-year-old with vomiting and yellowish discoloration of urine. The liver enzymes are highly elevated in this case. This is one scenario. I'll just introduce a few cases. This is the second case. This is a jaundice of 6 weeks duration in an 8-year-old child with no pre-existing liver disease. There is history of pruritus. The enzymes are mildly elevated, and the bilirubin is very high, and the INR is 1.4. So there's a moderately elevated liver enzymes with a raised alkaline phosphatase. That's another case scenario. The third is a fever, vomiting, malaise. I'll revisit these cases again. The third is a fever, vomiting, malaise in a 10-year-old of 1 week duration. The enzymes are very high, as in the first case. The fourth is a fever, jaundice, 2 weeks in a 6-year-old, followed by disorientation and somnolence. On examination, there are ecchymotic patches over the body with mild jaundice and flapping tremor. The enzymes are mildly elevated, but the bilirubin is very high, and the synthetic function of the liver is impaired. Now the fifth is a 4-month-old baby, a term normal delivery of birth weight 3.2 kg with jaundice at birth, phototherapy given and subsided, and then pale stools were noted at 3 weeks of life, which has persisted since then, reassured by the local doctor, and at 4 months presented with icterus and hepatosplenomegaly. The enzymes were elevated, the GGT was also high, and the bilirubin was 12.3. The sixth is a 13-year-old boy who is obese, weighs 72 kg, asymptomatic with no fever, jaundice, vomiting, no GI symptoms. And a routine blood check shows elevated liver enzymes. The seventh is a 12-year-old boy who was brought to ER with altered sensorium and deep jaundice with history of mild incoordination and difficulty with fine motor tasks in the recent past. There was history of consanguinity and a history of psychiatric illness in the uncle. The enzymes were elevated, the bilirubin was high, and the INR was also elevated. The eighth was a 13-year-old girl with tiredness, weight loss, abdominal discomfort, and yellowish discoloration of urine. The labs showed anemia, and the enzymes were in 4 digits. The ninth was a 10-year-old boy who presented with fever, chills, abdominal pain, yellowish discoloration of sclera and urine. The enzymes as well as GGT were elevated, and the bilirubin was marginally high. The 10th was a 3-year-old boy who presented with abdominal pain and jaundice, and the enzymes were elevated. The GGT was also high. The bilirubin was 3.2. This is the last one. It's an 8-year-old boy who presented with fever, abdominal discomfort, and jaundice. The enzymes were moderately elevated. The bilirubin was high, and there was leukopenia with profound thrombocytopenia. There was a pre-existing history of fever. So I just presented these cases, just indicated about these cases because these are myriad presentations of liver dysfunction in children. We'll revisit these cases again. A few words about LFT, and then we'll go back to these cases in the last 5 minutes. So this is a lovely article which came up in 2007. It's quite a while since this article came up, but this is a lovely, wonderful article by Thapa et al., which appeared in the Indian Journal of Pediatrics in 2007 about liver functions and their interpretation. So what does LFT indicate? It indicates the presence of abnormalities, may indicate a presence of liver disease. It may give you a clue as to the etiology of liver disease, the pattern, that is acute versus chronic liver disease, hepatocellular versus cholestatic injury, severity of the liver disease, and help in assessing the prognosis and monitoring the efficacy of treatment. But it has its own limitations in that it lacks sensitivity. It may be normal sometimes in cirrhosis or NCPF. It may lack specificity. For example, albumin may be decreased in chronic diseases as well as in nephrotic syndrome. So, while you look at the LFT, there are the tests of biochemical activity like bilirubin, AST, ALT, LDH, alkaline phosphatase, and 5-nucleotidase. The ones which indicate liver synthetic activity like serum albumin and prothrombin time. There are the tests of quantitative function which are obsolete nowadays. There are imaging studies like USG, MRI, CT, and HIDA scan, as well as the one to which we always return, the liver biopsy, which being invasive is not done too much nowadays, but still remains a gold standard in many diseases. So the tests, the liver capacity to transport anions and metabolize drugs, that is indicated by serum bilirubin. Tests that detect the direct injury to hepatocytes include the liver enzymes, SGPT, SGOT, GGT, and alkaline phosphatase. The test of biosynthetic capacity, as I indicated earlier. So bilirubin, there is a conjugated as well as unconjugated fraction. Conjugated hyperbilirubinemia is always pathological. So the normal range is less than 1 gram per deciliter, normal value. There are various methods of estimation of bilirubin. So increased unconjugated bilirubin may be due to overproduction, impaired uptake or conjugation. And increased conjugated bilirubin may be due to impaired excretion as well as regurgitation of bilirubin. But bilirubin may be lowered by drugs such as salicylates, sulfonamides, free fatty acids, which may displace the bilirubin from its attachment to plasma. So the serum bilirubin may be lowered by such drugs. And extreme hyperbilirubinemia is usually seen in severe parenchymal disease, sepsis, and hemolysis. Jaundice in neonatal period and early infancy, if predominantly unconjugated, may indicate cholestasis. It could be an intrahepatic cholestasis or an extrahepatic cholestasis. Urine abnormalities in jaundice, this is the most basic of slides, and I always remember Riya sir emphasizing on this. So hemolytic, the bilirubin is nil and the urine urobilinogen is positive. Hepatocellular, both the bilirubin and the urobilinogen will be positive. And obstructive, the bilirubin will be positive, but the urine urobilinogen will be negative. Urine bilirubin presence indicates hepatobiliary disease. Urobilinogen is markedly increased in hemolysis and increased in cirrhosis and malignant diseases of the liver. And in cholestatic jaundice, urobilinogen disappears from the urine. Now coming to the important component ALT, that is SGPT, that is released when cells are hurt or destroyed and more accurately reflects damage than AST. The pattern is very important. This is where the practical interpretation comes in. It is very high in viral, ischemic, and toxic hepatitis. Ischemic hepatitis is not of very high importance in children. In adults, in the setting of a massive MI and all that, ischemic hepatitis, and in hypotension, ischemic hepatitis is very important. But in children, I don't think it really reflects that much of an important component. It rapidly falls with increasing bilirubin, and if there is a rapidly falling ALT, in the background of an increasing bilirubin and INR, it indicates liver failure. AST is found in many sources and is not as sensitive as the ALT. It's not very specific for liver disease and often follows ALT to a degree. So, very high ALT and AST, think of acute viral hepatitis, drugs and toxins, as well as ischemia, that is circulatory shock. Moderate elevation, think in terms of acute hepatitis, neonatal hepatitis, autoimmune hepatitis, drug-induced hepatitis, and acute biliary obstruction. Mild rise, 1 to 3 times, think of neonatal hepatitis, NASH, cirrhosis, and drugs. AST to ALT ratio is important, more than 2 in Wilson's and CLD. less than 1 in viral hepatitis. That is, ALT will always be more than AST in viral hepatitis. I'm sorry for the busy slide. Alkaline phosphatase is found in liver, bones, kidney, and placenta. Liver alkaline phosphatase rises with obstruction or infiltrative diseases. In children, because of the growing bone, alkaline phosphatase may not be very indicative of obstruction. In that case, a GGT and a 5' nucleotidase can differentiate. Gamma GT, hepatocytes and biliary epithelial cells, pancreas, renal tubules, and intestine produce it. It's very sensitive but non-specific, and it confirms the hepatic source for a raised alkaline phosphatase. So, elevations in ALT and AST only suggest a hepatocellular injury. Alkaline phosphatase and bilirubin suggest a cholestasis or an obstruction, but mostly we find a combination of, that is a mixed pattern, that is both AST, ALT as well as bilirubin as well as alkaline phosphatase may be elevated. That's a mixed pattern which is mostly the common scenario, and we have to interpret from that. So, hemolytic, the transaminases are normal, the alkaline phosphatase is normal. Hepatocellular, the transaminases are very highly elevated. Alkaline phosphatase is elevated but not as much as transaminases. Cholestatic, the transaminases are elevated, but the marked elevation is usually in alkaline phosphatase. Albumin is a very important marker of synthetic function of the liver. It is not a reliable indicator in acute liver disease. It is depressed in cirrhosis. Cirrhosis, that is a chronic liver disease. It has an important prognostic value in Child-Pugh Sturcott scoring. And hypoalbuminemia may occur in a host of other conditions like PEM, nephrotic syndrome, and protein-losing enteropathies. So, it's not a very reliable indicator. Prothrombin time has a prognostic indicator in acute, and it is a prognostic indicator in acute and chronic liver disease. And acute, it indicates the likelihood of acute hepatic failure. So it is a component of both the MELD and PEL score, which are used to list a patient for liver transplantation. And a poor long-term outcome in chronic liver disease is indicated when you have a prolonged prothrombin time. Okay, serum ceruloplasmin, normal levels are 0.2 to 0.4 gram per liter and synthesized in the liver, and it is an acute phase protein. Its level is low in Wilson-Menkes, PEM, copper deficiency, and aceruloplasminemia. Alpha-fetoprotein is raised in hepatocellular carcinoma. Again, alpha-1 antitrypsin is an acute phase protein. Each one has its own implication, but let's go to the case scenarios as fast as possible. So, infectious hepatitis can be usually the hepatotropic viruses like the hepatitis A to E. The other viruses which are non-hepatotropic but nevertheless infect very commonly, as well as dengue, which is a rising culprit nowadays, as well as non-viral causes, bacterial as well as amoebiasis and the rest. Hepatitis A, acute hepatitis, and the enzymes are very highly elevated, self-limited, prolonged jaundice, there can be a cholestatic phase. HBV and HCV usually cause chronic infection, but HBV can also present as an acute infection. So, if the surface antigen is positive, indicates infection, and if HBe antigen, the envelope antigen is positive, it indicates an actively replicating virus. HCV, again, HBV and HCV are the ones that cause chronic infection. And in HCV, usually the acute infection is asymptomatic. In HBV, the acute infection is usually symptomatic. Hepatitis D is a co-infection or a super-infection. The others, okay, many other diseases can cause liver function abnormalities. Hepatic involvement in dengue fever, it's on the rise. And in a study which was conducted recently in the literature, almost 20% had transaminitis. And with dengue hemorrhagic fever and dengue shock syndrome, the transaminitis was on the rise. So hepatic dysfunction was seen in as much as 20% of children with dengue fever in many studies. So I'll come back to the cases again. So this is the first one. We'll deal with each of them taking a minute. So I just presented initially a few cases. Then I went on to liver function abnormalities, the individual components, their significance, and how they change in liver diseases. Now I'll go back to the cases again. Short febrile illness in a 6-year-old with vomiting and yellowish discoloration of urine. So short febrile illness is an acute illness. The enzymes have skyrocketed. They are in 4 figures. So the alkaline phosphatase is mildly elevated, but the GGT is normal. So the ALP elevation is not of significance. The bilirubin is 2.4. The INR is normal. So you have a transaminitis in a background of fever. So possibilities are, we thought of 3 possibilities when we have a 4-figure LFT, 4-figure enzyme. So it could be an acute infective hepatitis, viral hepatitis, or it could be drug-induced hepatitis, or it could be an ischemic hepatitis. So the possibilities here are an acute viral hepatitis or toxic causes, but there are no contributory history to that. So here the platelets are normal, the viral markers are negative, the synthetic function is normal, the chronic viral markers are negative, and the IgM anti-HAV is positive. So this is an acute viral hepatitis HAV related. So this is the first case. Now, jaundice of 6 weeks duration in an 8-year-old child. So it's slightly going into a subacute thing. No pre-existing liver disease. That precludes the possibility of a CLD. So no pre-existing liver disease. History of pruritus present, unless this particular case is an evolving CLD. History of pruritus is present. The enzymes are showing an elevation of SGPT and SGOT, but it's not that marked. It is a moderate elevation of enzymes. The GGT and the alkaline phosphatase are elevated. The bilirubin is markedly high. The synthetic function and the INR are normal. So, thoughts. This is a cholestatic jaundice. So, what are the differential diagnoses that we can think of? One is, it could be an acute viral hepatitis, cholestatic phase. Or, it could be a cholestatic condition like a biliary cirrhosis. Again, there is no history of any pre-existing liver disease. That is important. Say following a neonatal cholestasis or something. But then there is no previous history. The third is a biliary obstruction, like a stone disease. But again, it is still possible. We do not have any imaging at present. Or other cholestatic conditions like autoimmune hepatitis. Here, the IgM anti-HAV was again positive, and the viral markers, the HBsAg and HCV were negative, and the imaging was not showing any features of chronic liver disease or biliary obstruction. I'm trying to keep it as simple as possible. So this is an acute viral hepatitis, HAV related cholestatic phase. So we saw an acute viral hepatitis. We saw an acute viral hepatitis which has a prolonged hyperbilirubinemia and has gone into cholestasis. The third is fever, vomiting, malaise in a 10-year-old of 1 week duration. The enzymes are very high. It was like the first case. The bilirubin is high. The alkaline phosphatase is high. INR is normal. So high on cards is an acute viral hepatitis. But what is the question? Here the hepatitis A and E are negative. So the acute ones, 2 of them are negative. The HBs antigen is positive and E antigen is positive. Anti-HBc IgM, I'm sorry I missed out on that, is positive. HBV DNA is detectable and USG is not showing any features of CLD. This could very well be an acute hepatitis HBV related. I think I lost out on some time with the slides in the beginning. Anyway, fever, jaundice in 2 weeks in a 6-year-old followed by disorientation and somnolence, ecchymotic patches over the body, enzymes mildly elevated, bilirubin is very high and prothrombin time is very high. So this is acute liver cell failure, probably acute viral hepatitis or a metabolic cause related. Hepatitis A is positive and serum ammonia is elevated. Imaging is not showing any features of CLD. So acute viral hepatitis, HAV related, acute liver cell failure. Excuse me, I think that and your timing is different. That shows 16 minutes. Okay, case 5 is a 4-month-old baby, a term normal delivery. I was looking at it all along, so I thought I have another 4 minutes. Birth weight is 3.2 kg, jaundice at birth, phototherapy is given, pale stools and icterus and hepatosplenomegaly. Again, there is an enzyme elevation with a GGT elevation. So cholestatic jaundice of infancy, neonatal hepatitis versus biliary atresia is a possibility. USG showing hepatomegaly, gallbladder is not visualized, bulky spleen, and HIDA is showing a normal hepatic uptake, non-visualization of gallbladder, and no excretion of tracer into the intestine. Retention of tracer in the liver itself. So this is a biliary atresia. Sixth is an obese boy who weighs 72 kg at 13 years with no GI symptoms and just a transaminitis. This is a very common scenario nowadays. It could be a non-alcoholic fatty liver disease or a chronic hepatitis. The viral markers are negative. The FLP is deranged. USG abdomen is showing a fatty liver. This is a non-alcoholic fatty liver disease. The seventh is a 12-year-old boy who was brought to the ER with altered sensorium and deep jaundice. Again, features of liver cell failure, history of consanguinity, and a psychiatric illness in the uncle. Mildly elevated enzymes with bilirubin raised. Acute liver failure. Again, what is it? A viral hepatitis or a metabolic liver disease. With the history of neurological involvement and the consanguinity and the psychiatric illness, a metabolic liver disease, possibly a Wilson's, is high on the cards. Here the ceruloplasmin is low and the other workup is contributory towards Wilson's disease. The USG shows CLD and a KF ring is present. So this is Wilson's with acute liver cell failure. The eighth was a 13-year-old girl with tiredness, weight loss, abdominal discomfort, and yellowish discoloration of urine, high enzymes, and normal synthetic function. Mildly lowered albumin with anemia, joint pain, and a facial rash. Again, viral hepatitis, autoimmune hepatitis, and metabolic liver disease, but CBC showed mild leukopenia, thrombocytopenia, and positive autoimmune markers with negative viral markers, no features of CLD. So this was an autoimmune hepatitis. The ninth, well, I have two more case scenarios. Ninth was a 10-year-old boy who presented with fever, chills, abdominal pain, and jaundice, mildly elevated liver enzymes, and slightly elevated bilirubin. This is a nice case, actually. GGT was very highly elevated. So there was a triad of fever, abdominal pain, and jaundice. Mild elevation of liver, moderately elevated liver enzymes, and high GGT. So there is biliary obstruction. It could be a CBD stone because there is a history of cholangitis and highly elevated GGT. But rare possibilities like choledochal cyst should be thought of. The other possibilities are acute viral hepatitis as well as autoimmune and metabolic liver disease. Here the amylase was elevated. That is again in favor of a biliary pancreatitis. USG abdomen was showing gallstones with distal common bile duct stone and proximal biliary dilatation. The child had to undergo an ERCP, stone removal, and biliary stenting. So choledocholithiasis with cholangitis and biliary pancreatitis. The 10th one is a child, small child, with again the same features like abdominal pain and jaundice. No features of cholangitis as such, but the LFT is showing an obstructive pattern. And again, it could be a CBD stone or a choledochal cyst, as well as the other possibilities are lower down on the cards. Amylase slightly elevated, and USG was showing a fusiform dilatation of the CBD, and MRCP was corroborative for a choledochal cyst. So it's a smaller child, no typical triad with a choledochal cyst. The last is an 8-year-old boy who presented with fever, abdominal discomfort, and jaundice, moderately elevated enzymes, prothrombin time normal, bilirubin slightly elevated, and there's a background of fever, and there was leukopenia with profound thrombocytopenia. So this could be again a viral hepatitis, other infective causes, metabolic and CBD obstruction very low on the cards. So here the labs had shown leukopenia with thrombocytopenia. USG was showing findings of serocytis, hepatomegaly, GB wall edema, and minimal ascites, and the dengue workup was positive. So this was a dengue fever with a hepatic involvement. So I just tried to present in a nutshell how very many times LFT could be deranged in children in very many clinical scenarios. It could be a hepatocellular involvement, it could be a cholestatic injury. So in a nutshell, LFT helps in diagnosis, assessing severity and monitoring progressive liver disease. Each component has a specific implication. A single LFT is of little value, so that is why we are asking for serial LFTs. And in conjunction with other parameters, it's very valuable in liver disease, and overall, it is to be interpreted with caution. I'm sorry for exceeding time, and thank you so much for your patient hearing. Thank you so much.
Thank you, Dr. Rama. I think so you can come over here and take your breath. She was like going like the Rawalpindi Express for some time. So I think she can take a breath now, and we'll take the questions after the session, okay?